Do you want to be here or do you want to be sitting? Whatever you want. Welcome, everybody. My name is Michael Barron. I'm with the League of Women Voters, but this is part of our public policy series that we do with Case Western Reserve Siegal and with the Plain Dealer and Cleveland.com, and our corporate sponsor is First Interstate. Tonight, we're doing a forum on universal health care, and we have a good panel. Our moderator is Ginger Christ, who writes about health care for the Plain Dealer and has been a reporter in Ohio for the past decade. During that time, she's covered transportation, manufacturing, real estate, business news for local newspapers and national magazines. Ginger's worked at the Plain Dealer for the past 2 years and was the newspaper's transportation reporter. In that role, she covered public square, bus debate, local and state transit funding shortfalls, and multimodal transportation. Ginger grew up in Northeast Ohio and moved back to the Cleveland area 6 years ago. Ginger?
Hey everyone, thank you so much for coming. As Mike said, I'm Ginger. I've been at the Plain Dealer now about 2 years, but I've been on the healthcare beat just for the past year. About a year ago, our newspaper did a reader survey, and they determined that we should be dedicating more of our resources to healthcare coverage, given how large of an employer it is here and how big of an effect it has on everyone's lives. So I'm healthcare now, technically the business of healthcare, which is probably why I'm here today. So that said, since I took over covering healthcare, last year was when, as you're all familiar, there was a lot of healthcare reform debate going on at the federal level. That's a lot of what my early coverage focused on, and really where a lot of my effort has gone. And so I think that while we didn't actually have major changes in healthcare reform last year, I think that kind of really set the stage for a larger discussion on healthcare in the country. And kind of like the discussion we're going to have here tonight is, you know, what is the best way for us to deliver healthcare here? We know that in the U.S., healthcare costs are about twice that of other developed countries, and we know that people are unhappy about, you know, the way healthcare is delivered. And people can argue that over partisan issues on, you know, what the right solution is. But what we're going to focus on here today is just, you know, one possible solution, and that is universal health care. So we have these fine panelists here who were all gracious enough to volunteer their time tonight, so we thank them for that. And they each come from different backgrounds here in the healthcare community, and they're going to share their insights with us and just talk about, you know, universal health care. Could it work here? What is it? We've heard a lot about single payer, but that's kind of a bit of a misnomer. We're going to talk about universal health care. And yeah, so let me introduce our panelists. We're starting here with John Corlett. He's the president and executive director of the Center for Community Solutions. That's a nonprofit think tank here in Cleveland. They focus on health, social, and economic issues here. He also is the former Medicaid director for Ohio. Next, we have Susan Mego. She is the executive director of managed care for MetroHealth. She's also on their population health team, and she teaches public health at Baldwin Wallace. And at the end of our panel, we have J.B. Silvers. He's a health finance professor at Case, and he also serves on MetroHealth's board of directors. All of these people are people that I have reached out to on stories. I've talked to them. I rely on them to help explain things to me because, as we all know, healthcare is very confusing. So hopefully they can help educate you guys tonight, and we can all have a good discussion. So to start, I'm going to head to John and just let him give you a little bit of background about his experience in healthcare and how that's going to frame his discussion of universal healthcare, and then we'll just go down the line to start.
Good evening, everybody. Thanks, Ginger. Thanks for the introduction. Thanks for having me here tonight. So I'm gonna. Can you hear me with the microphone? Okay, great. So as Ginger mentioned, I was state Medicaid director. I worked for Governor Strickland as his Medicaid director for about 2 years in Columbus, and And so the piece that is sort of interesting to me about this, that has sort of entered the debate right now, the policy debate, is the notion of whether we should have Medicaid for all. There was a bill introduced last summer by Senator Schatz from Hawaii, along with 17 other all Democratic co-sponsors, to allow people to be able to purchase or buy into the Medicaid program. And so when I was kind of looking at this, I'm a little skeptical about it. And I'll talk, and I want to talk a little bit about some of the advantages and disadvantages of it. But I found a Paul Krugman column from 2013, from the New York Times, Paul Krugman, and he said, and the future of his column was, "I have seen the future, and it's Medicaid." And he said that because when he looked at how the Medicaid program was managed, its cost growth was the lowest of anyone. The administrative costs generally in Medicaid are about 2%. Whereas in private insurance, it's anywhere from 13 to 15% in terms of administrative costs. So it has low administrative costs. It has relatively good outcomes. Good care is provided. But they also are able to keep those costs low because they're also willing to say no. And that helps them get lower prices and refuse some what would be considered kind of low payoff procedures. And it now covers 1 in 5 Americans. In Ohio, it's almost 1 out of every 3 Ohioans is now covered by the Medicaid program, particularly since the expansion. The expansion added about 700,000 previously uninsured Ohioans. They got coverage through that expansion. And some people have referred to it as kind of the on-ramp to single-payer health care, that it is one of the ways to get there. But I should say, though, that even if we provided a Medicaid for all health care, if it were to pass and move forward, even if we do it does not get to universal. And I think a lot of the proposals that I've looked at, they don't get to universal in terms of covering everybody. But let me talk a little bit about what I think some of the advantages would be, and then I also want to talk about what I think some of the disadvantages would be. One I mentioned was the low administrative cost. Part of his proposal would be to upgrade the payments to providers from Medicaid levels to Medicare levels. Medicaid pays providers less than the Medicare program does. And we had some experience on the Affordable Care Act for 2 years. We boosted payments to physicians who did primary care and those type of services to Medicare rates. And there was indication that brought more providers into the Medicaid program. More people were willing to see patients when their rates were boosted. It could offer lower premiums than the private insurance plans that are now offered through the exchange, so it could compete with those private plans. It might also, one of the other things that people have suggested is that it may be more aimed at higher income individuals, because if you think about it, those folks who get their coverage now through the exchange, who have higher incomes, who don't get any subsidies at all, they are probably some of the most disadvantaged right now because of what's happening with rates through the Affordable Care Act. And so this plan could help those individuals out maybe even more than some others. It would also, it would give the program access to the Medicaid drug rebates that Medicaid gets that other programs don't get. And it's also broadly popular. Medicaid is a broadly popular program. It's well known. It also, from a political standpoint, it has strong interest group support, meaning there's, providers, insurers, and also, both a plus and a minus, depending on how you look at it. There's also a lot of employers who depend on Medicaid to provide coverage for their workers. And so it may provide a political constituency to expand it. Now, the disadvantages are when the Congressional Budget Office scored a similar plan during the Affordable Care repeal debate, it found that it would really have no significant impact on improving coverage. That it doesn't really move us very far forward on coverage. But it might provide a path to get us there. It might show us a way to get there. There are still affordability issues. Unless you set subsidies at a relatively high level, you're still going to run into problems with people being able to afford coverage. It also might lead to more narrower networks. Narrower networks are where you get your coverage and you can only go to these 3 people. You can only go to this hospital or this place to get your test done or whatever. It could lead to more of that. It would probably also cause more employees to drop coverage because they could say, they'd point to this Medicaid for all option. And that might be would be the instance with a lot of these proposals that are out there. it gives states flexibility, but yeah, we have state flexibility now in Medicaid, and I think there, what is it, 17 states that haven't expanded? I mean, since, particularly with the Supreme Court decision on the Affordable Care Act. So, flexibility might be good if you lived in a state where somebody wanted to do this and wanted to offer a good program, but if you lived in a state that didn't, I just saw, for example, I think it was 2 days ago, Mary Taylor, who's running for governor on the Republican side, released a TV commercial saying that she would end the Medicaid expansion if she were elected governor. So it shows, that can make these things relatively fragile in states where there's not the political support. And then, there's also cost issues, in terms of how we pay for it. But that's going to be the case with any of these proposals. We have to figure out how to finance it, although I think we just gave a $1.5 trillion tax cut to some of the wealthiest people, so that might be a place to look for some of the funding. So I'll stop there.
Just end on that nice, totally unbiased line there. All right, Susan, we'll move over to you.
So how do I follow that? Right? Okay. Can you hear me okay? Is that fine? Yes? A little bit more? There we go. Well, I'm fortunate to have experienced the health industry from a number of perspectives. My career spans both the insurance industry and the provider side of the business. So those are two different forces that sometimes are competing with each other, but really are dependent on each other. And I have the luxury of being able to hear both sides because I've lived both sides. More importantly, I've experienced as a consumer. And so I have my own list of issues that I'd like to see fixed in the future, but I have my concerns at how we make that evolution. I'm glad we started with talking about single payer and universal health care terminology. We'll probably touch on that a few times today because they're different concepts and they're both in play. With the single payer being the focus on who finances the health care, who funds it, where's the money come from to pay for it, and how is it administered? And right now it's administered by lots of organizations. So there's lots of different unique ways of doing business. As a provider, we have to do business at MetroHealth with many, many different payers who are each in their own design of how to administer things. That becomes very cumbersome. So a single payer approach seems simpler. But with it comes a much bigger scale. Everything through one organization would be a big bureaucratic undertaking compared to small sets of business operations. But the universal healthcare side is what comes out of that, is the set of what's covered and where can I get that coverage? What's the delivery system for that care? Both of those need to be addressed. And if we do it in sync so that one doesn't damage the other, we have a good chance of evolving as a country into something that's the next generation of how to access healthcare and how to get healthier. And you'll see some of my comments today are going to be geared toward, let's keep our eye on the prize, which should be healthier outcomes, not just redesigning for the sake of redesigning. Every stakeholder should be able to win. If the measure of is it effective has to do with are we healthier as a population? Are the benefits that are being designed in universal health care, for example, motivating us as care-seeking individuals to get care when we should, which is early, right? Preventive care. And it's not just because it's free and no cost when you go to see the doctor, nothing out of pocket right then and there. It's because there's something about the way it's built that makes you change your habits. Habits change slowly, right? So hopefully those kind of things are what everyone benefits from, where it doesn't become just about how do we fund it or how do we administer it. And we'll touch on those today. I also wanted to just share, as we touch on universal health care also in existing in other parts of the world, we're likely to hear lots for many, many years of which other country we should mirror. And I have a feeling, we talked a little bit earlier in the audience, that we only hear the shallow version of how good or how bad it is. It's usually a very one-sided argument. It either fails everyone or it saves everyone and it's the best thing since sliced bread. And it's probably neither. And what we'll experience, in my opinion, is if we choose any certain model to mimic, we will never achieve the same outcomes as that country because our starting place is different. We have different tolerance levels of change because we already have something that we're moving from. So if things get stricter or taken away or different choices, that's going to be just as uncomfortable as what we have today, where it feels restrictive or it feels cumbersome. So we have to be careful that what we're changing to is a kind of an eyes wide open approach. We have to know what's under the surface, kind of look under the covers, what's really driving the way things are. So we're changing those things, not just the overall arching design. Or we'll end up just a bigger version of some of the problems we have today. One size doesn't fit all. And I think it's time for us to really start to get into the detail of what drives the system toward that end that I mentioned. What could get us the healthier population more affordably?
Thanks so much.
Yes.
All right, let's move over to you, JV.
Well, I looked over and I see these two with all these extensive notes, and I just have one little piece of yellow paper here. So let me.
I've done a lot of interviews with you. I really don't think that's going to stop you.
Well, what she means to say is professors profess. All you have to do is turn the dial. How much do you want? So we'll do a little bit. I won't go on for too long because I'd like to have I think the interchange is going to be probably more important. I'm sort of the Forrest Gump of healthcare up here, wandering around the health system doing all sorts of oddball things. Just thinking back, the first I did in Ohio was chairing a commission for, I hate to say this, but Governor Celeste. That tells you how long it was on Medicaid. But a few years after that, I've been on a number of other panels like that. Probably the biggest one was, it's now called MedPAC, Medical Payment Assessment Commission, Advisory Commission that advises Congress on Medicare. So I spent a lot of time worrying about financing issues and health care, but this was a chance to actually get into the guts of how Medicare works, and particularly around the payment processes for Medicare of hospitals and what impact that has and what impact that has on the rest of the country. So I did that for about 7 years. I was on the board of the Joint Commission that is the major accrediting body for healthcare facilities, certainly in the U.S. and mostly and around the world too, for about 12 years. And that, again, that's the second part of the Forrest Gump thing, because they deal with quality. You know, how good is our facility? What are we doing? And that's the other part of what we think of now as value-based care. How do we look at the product? Well, it costs a certain amount, we pay for a certain amount, and then we get a certain amount of quality out of it. So how do we put those two together? Along the way, another little side venture, I was CEO of Qual Choice Health Plan. I have to ask, I always want to know, how many people here were insured by Qual Choice at some point? Oh, that's so sad. There's so few of you out there. It was the University Hospital's captive insurance company for about 10, 15 years probably. They decided to disband it and sell it off to Anthem. But those were some interesting periods because now I had to sort of put those together and think about it from an insurance company point of view. So how do you take care to a population and do it right? We got 2 J.D. Powers awards, and we actually did it profitably. The place was about to go under when I went there. And I thought it was interesting because we actually found out how to do things, I think, reasonably well from an insurance company point of view. The problem, of course, is that it cost money to do that. You know, we've spent 15% or so of the premiums on the management side of that. And the big argument against having private insurance companies of any sort, profit or not for profit, mostly for profit, is it costs too much. Medicare and Medicaid, as John mentioned, do it for a lot less money. So is that a better way to do it? Well, that's one part of it, is the transactions cost. How much does it cost to get things done? But there's a lot more to it than that in terms of what Susan was saying. That it's how you structure the system and what kind of incentives you create for the people that are out there. We will not have universal health care in that broadest sense because that basically means we're all in the VA. We all are in a captive system where one body owns everything. So people usually aren't talking about that. What they're talking about is one payer. So that's where the Medicare for all or the Medicaid for all. And the usual argument for that is that, one, they can use their market power to dictate prices because the marketplace hasn't worked very well to get good prices out of the system. And two, they can cut the administrative cost. So instead of paying 15%, they can do it for less than 5%. Now, can they do that when they're running the whole system? That's a moot point. That's difficult to say. But that's part of the argument. And then in recent years, the last, 4 or 5 years now probably, I've been on the board at MetroHealth. And that's, again, getting it from a different point of view. The big insight from MetroHealth that's interesting, and it ties back to somewhat what John was saying, is that the first year of the Medicare expansion, Ohio chose not to do it. We weren't in that first thing of the Medicaid expansion under the Affordable Care Act, but MetroHealth decided that we were going to take the county subsidy and run it through the Medicaid program and get the federal match and insure people in Cuyahoga County that otherwise wouldn't have had insurance. And he's modest about it, but John was the major reason why that happened, because he was doing that at MetroHealth at the time. And you can help me with the exact numbers, but I think we had almost 30,000 people. 38,000 people that we covered that would not have had health insurance. So that's the first thing, is that's a health system providing direct care, providing both the insurance side and the delivery side, and which is sort of an interesting model right off the bat. But the second thing was that we did it for a whole lot less money than what it cost other people. 27 is the number I carry around.
20.7.
When you looked at the total cost per member per month, is the way that we look at that. The total cost of care for hospital, doctors, everything that Medicaid pays for, we came in 28% less than what it would have cost had those people just been wandering around the system in a normal pattern. Now that just sort of opened my eyes wide as to the potential of putting those two sides together. As difficult as it is, how are you going to put both the delivery side and the payment side together in one package? And so I think rather than saying single payer, we need to think about, how do I integrate the package in a way that makes sense? And it's not just Medicare for all or Medicaid for all, it's other forms of contracting. Susan's been working on contracts that where we take the total cost of care for a population, and we have an incentive to do that really well. There are other models out there, the accountable care organizations, where we're looking at the total population. So what we're thinking about, I think the movement, part of it besides just the political side of single payer, is how do you change people's behavior in a way that saves money and provides a high quality product to as many people as you possibly can. And whether that approaches 100% or not is a political issue, pure and simple, a political issue. Are we willing to spend that amount of money or not? And that's the big question, is what's our political will? The method of how we get there is more down in the weeds about how do you organize this? How do you pay people? How do you put things together? And so we need to think about that, and I think that's what Susan was alluding to, rather than just Medicare for all. The phrase is a little bit too shallow to get to where we really want to be. We need to think more deeply about this issue than just this. So with that, let me stop.
All right, thank you guys so much. And one thing I realized I didn't mention at the beginning was kind of the format of tonight. So where we're going to go from here is I'm going to ask questions for the next half hour and let them respond. And then with the last half hour we have left, these note cards that Mike's passing out, you guys can write questions down. He'll give them to me, and then I'll ask them for you. It just saves us some time that way, and we can get through more questions. So anyway, I'll lead off because I have the microphone now. And I'm just going to say, kind of how you ended that, JB was talking about it's really going to be a political battle on what we do. And I think it kind of goes to that question that we have, or that divide we have, which is healthcare a right or a privilege? And that's what we're kind of dealing with. So what do you guys think needs to happen for any of these ideas that we've started tossing around to happen? What needs to change, or what do we do to get to that change? Whoever wants to start, feel free.
John, you're closer to the political side than the rest of us.
Well, I mean, we need a political change. We need a political change in this country to do that. And I think this may be a little bit cynical on my behalf, but I think that's what's driving a lot of the proposals right now. Whether it's the Medicare for all, the Medicaid for all, the Medicare buy-in. I think a lot of that is aimed at the 2020 election. People are already thinking ahead to the presidential primary, and particularly on the Democratic side. So people are trying to distinguish themselves, and they're not. And it's not that they're not serious proposals. I think they are serious proposals. But I think a lot of this now is trying to get a sense about, what's the appetite, particularly on the Democratic side, to sort of tackle these things. I mean, but I think there'll be caution there, because the last two times that the Democrats seized both the White House and Congress, in 1993 and in 2009, was when we undertook pretty significant health care initiatives. And it was both after those times that there were wave elections that knocked them out of the majority of both houses, and they lost the White House. So I think there's a political calculus that's involved here for people as well, and I mean, it was even President Obama, he had that phrase that he talked about: if you like your plan, you can keep it. And that proved not to be true. And I think that really came back to haunt him, and haunted, I think, the ACA for a while. So I think, politics are certainly a part of this. But, I always tell people I'm an optimist. And so I think and the other thing, a credit to the Republicans this last year, they succeeded in making the Affordable Care Act more popular than it's ever been in its history of its existence. I mean, it was only after they tried to repeal it that it finally was over 50% in public opinion polls, and also I think, from a Medicaid standpoint, the fact that they tried to repeal Medicaid and tried to end the entitlement to Medicaid, I think made people understand how important that program is. People were always surprised when they found out that half of the births in the state are covered by Medicaid. That it's the largest single payer of long-term care, skilled nursing facilities. So when people they helped us sort of elevate it through that debate. So we owe them some thanks, at least for that.
Okay. Does anyone else want to add in?
I will.
Okay.
So I'll take the politics part to a different level. So there's the politics the way John described it, but there's also this constant push-pull on the business side. So think of it in the most simplest way, that each of us are consumers of healthcare, but we're also employees of somewhere, likely, and things that happen in the business world affect our employment, right? So you've got those forces going on saying, don't change because I wanted to build another location there, and if you do this, I can't afford it. All of a sudden, we're thinking like these vested citizens, and how is my life affected, more than just how do I get a different kind of health care. So there's this undertone of what happens with all the different stakeholders. And it's more than just the politics that are at the highest level. It's the politics of how we do business in America that gets involved. We don't want too much change, just enough change that helps us, right? So we have to figure out what again, look under the covers. What are those things? Is there a way to cause some uniformity in what we already have that didn't change who's in business dramatically, but reduce the marketing costs, reduce some of the competition costs, trying to solicit our enrollment, but we still get choice? Is there something we can do that affects that push-pull between who pays and who gets paid, right? So what's the right reimbursement level to have just enough access to make sure all of us have convenient care? If you pay too much or too little, that affects where providers want to do business, right? So some proposals out there for universal health care talk about reducing the provider rate enough that folks leave business as a provider, and it kind of thins the pack, so to speak. But what'll happen? There'll be areas without providers in certain specialties geographically, and what will you do then? Wonderful package of covered benefits, but you don't have access to the same set of providers you wanted to use because something happened in their dynamic, their reimbursement change. So all of those undertones affect what's easy to implement and what causes another outcome that might be the next big problem. So we have to be really careful to be respectful of those and figure out how do we get that balance for the stakeholders.
I've been looking, just in thinking about this, probably the case in point, if you want to look at it, is California. California, this is a central part of the current campaigns that are going on right there, around there. And it goes back to the same issue. This will cost us too much. Among the two leading Democratic candidates, you're having opposite positions. One, this is the only chance, if we don't do something about it, it's going to bankrupt the state of California. The other one says this is too expensive, we can't afford to do it. Now that's really interesting. I found today on the web a report by a former colleague now at the University of California, Berkeley, that has stated three major things that have to be done to make it work. And they basically say that we have to change the way we contract with the system. If you're going to have a universal payer, one payer, in this case the state of California, one, you have to get everybody else on board. So you have to somehow figure out how to do the political landmine of getting the feds and the state Medicaid program and the Medicare program to all put their money in the pot. And then get rid of the health insurance companies, another major issue right there. So trying to get to that point is really hard. But then they said we have to get everybody into some organized form of care. Medical homes where there's a consistent point, for instance. And they had two or three other major things like that, which interestingly enough are going on right now. They're things that at MetroHealth we've done for a number of years now, primarily, which is the reason why those numbers came out the way they did. But can you focus people to the best providers? Can you create a narrow network to drive them where you need them to think they best should go? Can you use your marketing power to bargain good rates? And a variety of things like that. Now, this gets back to Susan's point. If you really want to do that, and people in California might vote for that, they might try to do that, the only way you can make it feasible is to save a lot of money in the healthcare system. Because otherwise the tax rates would go up, and they're talking about 50% sales tax rates, things like, I mean, they're using really ridiculous numbers, but enough to scare people. Well, that's the kind of thing you would hear if we got to the point. How are you going to finance this expansion to everything? And the numbers would scare particularly conservative people in Ohio. We just wouldn't get past that. Can you move towards something like that? Absolutely. So can we find ways to get people into networks that will actually provide good value and lower the cost and quote, bend the curve? And I think we have begun to do that under the Affordable Care Act. There's some really interesting things that have happened under the Affordable Care Act that have moderated that a lot. And so the forecasts aren't anywhere near as dire as they used to be, but they're still pretty dire. You know, when you look at this, the old joke is that the federal government is a big insurance company with an army attached to it. Well, you know, that would be even more true. That's basically what we've got. And we don't, most people would not like the state of Ohio to be the same thing without the Army, you know, maybe with the Ohio State University attached, but not much else. And it'd have to be smaller to pay for all this. So, you know, that it's reallocating the money that's the tough part. That's the essence of the political issue is we spend so much on health care. It's just truly amazing to me that we spend so much more than anybody else, and we still have everybody mad at each other. That's really a remarkable accomplishment.
All right, so there's so many directions I want to go, and if this were one of my interviews, I would ask them all in a big jumble, but I'm not going to do that to you guys. We're going to do one question at a time. So I think where I'm going to go now is, you know, the Affordable Care Act designed to make sure that everyone was able to get insurance. So do we think that the backlash from that is moving us closer, as JB was saying, to maybe this idea of single payer, or do you think that would maybe move us farther away because of the unpopularity of decisions like that?
I don't think anybody thought the Affordable Care Act was going to cover everybody. I mean, I don't think they ever had the intent of covering everybody because not everybody was eligible for the coverage. I mean, if you were, you know, for example, you know, undocumented or, you know, not here legally or whatever, you weren't covered. There's other groups that weren't covered. So I'm not, I think, you know, one of the points that Susan and JB both made, I think is really important. And that is, you know, even if we get to universal coverage, for example, or get everybody covered, I don't know that it leads to better health outcomes. I mean, because so much, I mean, our health is determined to a small degree what our physicians' hospitals provide. It is all the other things around us. It's the environment we live in. It's our own personal behaviors. You know, I mean, one of the things that used to drive me mad as the Medicaid director was that a third of our beneficiaries smoked. You know, and a lot of our pregnant women who were covered by the program smoked. And I'm like, you know, we got to change that. You know, there are other things, and so I think the social determinants of health. You know, I mean, like there was a really interesting study that was done last year where at Johns Hopkins University, where they provided low-income individuals who were both eligible for Medicaid and Medicare together. They're called what we call dual eligibles. They gave them $10 more a month in SNAP benefits and food stamp benefits. And they reduced their hospitalization rate. They reduced their time in skilled nursing facilities. They saved money. I mean, it's those are the things I kind of like sometimes because they're like common sense. Like I can explain to somebody like, well, if you give people access to healthy food, maybe they stay healthier or whatever. But so often all of our programs are in these little silos, and like you can't do that. You can't sort of provide funding for those things. So I think we have to take a larger look, and I do think coverage is important. I think that's kind of a core thing. I do think healthcare is a right, but I also think we've got to look at some of these bigger issues, and if it's just healthcare that happens inside MetroHealth or University Hospital or Cleveland Clinic, that's not enough. And part of this is also trying to figure out how to get some of the resources out of these big players and get it into public health and some of these community activities that might have a more profound influence on people's health.
Does anyone else want to?
There are so many comments I want to make. But I'm glad we're touching on so many things here. One thing that hasn't been said about the ACA is anything you do like that, any innovation, Medicaid for all,
Right.
Anything we've talked about, you need to give it time. So we're reacting to its introduction. And the businesses who operate those different ones are trying to stand them up. They're trying to get enough volume, make sure that the way they did their financials predictions are close enough to reality. They're still kind of reeling, trying to get it right. And we tend to shut things down in this country before we give it enough time to mature and say, what could it become? And I think it takes us back to, and it's unavoidable. It's not one instance, it just happens. But it takes us back to what we're talking about is what are those incremental changes, regardless of which model you're in, that get us to the end we're all talking about. Mm-hmm. It doesn't have to necessarily happen in a single payer system or in a certain kind of design. It can happen where there's lots of players, but it becomes an expectation. It becomes something that's part of everyone's coverage, and again starts to change behaviors, starts to change how those organizations work together. But if we keep expecting a miracle and then shut it down to say, well, that was no good. Yeah. Well, no, it was the beginning. It was the beginning of good. Now, what was good about it that we can translate into something else? Much of what we done, you guys have done a great job marketing for me. I didn't have to share any of my history or programs because you did. But much of those things fed onto each other. Said, wait, we've learned this here. Let's apply it here. Now another year goes by. Let's try it in this design. And we're learning from each one which things have the biggest impact. And that's what we need to do as we do this evolution in healthcare in the U.S. is keep building on it. Don't trash it and start again. Build upon it. On the good parts of it. Don't be afraid of the redesign. The redesign is part of that maturing process.
Well, but that's the American way, Susan.
It's
really.
exactly
Come
what I'm
on.
saying. That's exactly it.
It's even harder
It's
when the rules keep getting changed on you
Yeah.
and when the government reneges on payments they're supposed to be doing. I'm very sympathetic. It's hard to be sympathetic to insurance companies, and it took me years of therapy to get over my feelings of rejection after running one, but nobody loves their insurance company. It just doesn't work very well. But in this case, they really didn't have much of a chance. And I think that's part of the issue. Let me be more provocative, though, and say that, because I think your question was, how are we going to get to the next stage somehow or another? And it's probably incremental, as you suggested, but I think it could be more cataclysmic in some ways. I wrote an article maybe 10. First of all, I have to say I really appreciate the last year, though. The Republicans did a great thing. I wrote so many op-eds the last year, including 3 in the New York Times, that never would have been published if it hadn't been for those crazy people in Congress. It's just, I thank them very much for this. But let me be provocative. I wrote an article probably 7 or 8, 9, 10 years ago. I never published it because I didn't think the time was right, and I'm wondering now if maybe I should dust it off and send it out, called The Death of Health Insurance. And the provocative part was that insurance, the financing model that we use of some sort of pooling mechanism that works, is based on the idea that I can predict that I have events that I can't predict at the individual level, but I can predict them at the population level. So I don't know I don't know whose house is going to burn down, but I can look at the number of houses. I don't know who's going to get hit by a car or whatever. Well, the same model, we basically use that for health insurance. So I don't know how many people are going to have this happen to them, but over a period of time have to have hospitalization. X number of people in the population are going to get it. Therefore, I can spread that, I can pool it, I can spread it across time. Let me argue that that model works as long as I have events that I cannot predict at the individual level. But an increasing part of what we know is wrong with people in today is chronic care conditions. So when I have rheumatoid arthritis today, I'm going to have it next year too. If I got diabetes today, I'm going to have it next year, and I can predict pretty well what my expenditures are going to be. The more that I can predict what's going to happen at the individual, the less insurable that is. And therefore, the more we're getting closer to the failure of health insurance as a concept. This is a broad notion of a concept. Leaving the only possibility is universal coverage of the broadest possible pool. And I think much of what happened in the ACA is we've tried to create smaller pools that are too small to be economically viable, particularly when there are some environmental changes going on. That might be the thing that puts us over the limit and says, look, the system as we know it of individual insurance pools is just going to fail. In which case, then I have to do something special. And more, I think it's chronic conditions. The second one is genetic information. This gets more difficult, but if I know you're predisposed to do something, then over a period of time, I've got a pretty good idea what's going to happen to you. Now, that's nowhere near at that point, and we have legal protections against that and a variety of other things. But I think we run the danger of a failure of the insurance model, number one. Number two, I think some of the change might be because of the collapse. The second one might be because of a change from, of all people, large employers. Most of the people have their insurance not through these other mechanisms, but through self-insured employers. We think it's insurance. I carry an Anthem card around in my pocket, but it's not Anthem that's paying my bills. It's Case Western Reserve. When I spend money, it comes right out of their account. There's an administrator. They're acting as administrator to pay the claims and all. So there's an incentive for the employer to do something about it. The op-ed that I'm about to send out argues that the third wave of change, which I think we're seeing right now when you see what Amazon, J.P. Morgan, and Berkshire Hathaway are getting ready to do, is to tackle the obvious market issues that are involved. I call them transactions cost. The fact that it costs so darn much to pay claims, it costs so much to do the contract, the administrative cost is high. The fact that the pharmacy benefit management companies basically are ripping off the system to some extent and not giving it back to us. The fact that we have, I hope we have nobody here who's in this category, that we have brokers and consultants that are taking money from both sides and biasing the decisions of people in terms of what plan they choose. That the formularies are not necessarily independent because they're not done just by the docs, which is what I did at Qual Choice, but they're influenced by the amount of rebates that are coming back from the big drug companies. Those are market imperfections. Those are transactions costs that you can tackle. And Amazon is going to go after them. Mark my words. They're going to go after those as major changes. And the next thing they'll take on is the insurance company. Why do we have to have an insurance company? Well, because they do pay claims and write contracts. And they do pooling. Well, I don't need to pooling anymore. Forget that. I got plenty of employees. Do I need them to pay claims? Well, I'm pretty good. I got PayPal and all kinds of other stuff out there for that. Amazon knows how to do that. You're going to see people going back up the value chain to get rid of all the places that we don't do a very good job right now. And this has a peripheral impact on the providers, but it has a very dramatic impact on this. And then the next step is to go after the random pricing behavior that we see that Congress wants to make transparent, but they don't know how to do it, that we mess up all over the place, and I'll be in trouble for saying this, through our charge masters that make prices for things we do that nobody ever pays and just are designed to scare the hell out of you when they get the explanation of benefit, and shows you how much their insurance company has saved you when it really didn't save that, because that's not what the contract said to begin with. Why do I have to do that when I can go up the value chain and directly contract with providers for bundles of care and get good prices for them and demand quality and do what Amazon already does across the board. So let me argue that besides market failure on the insurance side, that's one way we might get to where you want to go, Ginger. The second one might be the actions of large employers actually doing what they do pretty well. And that may be enough to get the system to change in some dramatic ways. Is that provocative enough?
I like it. All right. So we've done a lot of kind of high-level discussions of this concept. I want to kind of take it down a step and talk about some of the plans that are actually out there. John started earlier by talking about this proposal for Medicaid for all. There's also the idea that Senator Sanders had for, Medicare for all. So can we kind of break down those two ideas and explain, really what the difference would be and other plans too? But I really want to just give people an example of what these options could look like should we make any of these changes that we were talking about.
Well, I mean, I can talk a little bit about some of the difference between the sort of the Medicare for all and the Medicaid for all. First, we just have to remember the difference between Medicaid and Medicare, which is half of our politicians don't know. But I mean, some of the difference, Medicare is entirely federally financed. There's no state financial participation in the Medicare program at all. It's entirely federally financed. It is, so it's nationwide. There are some challenges with Medicare for all in that Medicaid has covers more things than Medicare does. For example, Medicaid covers long-term care, covers dental care, things like that. Some of the things that Medicare doesn't cover, and so you kind of have to sort through some of that in terms of what might be part of the benefits. Medicare, although I think Senator Sanders' proposal calls for no co-pays, no cost sharing, that the consumer wouldn't pay anything for it. But Medicare today, as anybody who's on Medicare knows, that there are all sorts of different costs that the person has to pay, whether for their Part B or their Part D or those kind of things. And so you'd, I think, have to figure out how to finance that, how you would pay for that, to JB's point. So I mean, those are some of the differences. I'm sure there are others. I mean, we could probably get down to the weeds of this and parse all of it. But those are some of the things that jump out to me. I don't know, JB or Susan, if other things jump to you in mind and what would be different about one or the other?
Well, I think the obvious first step is what the state's done with Medicaid. If you don't want to run it directly and you think private enterprise does a good job, contract it out to managed care companies. So if I had to guess how Bernie would actually get something done, he would go to Medicare Advantage. And so we would have Medicare Advantage plans offered to people, which folks generally like, and they've done a reasonably good job. But you still have embedded in those the administrative cost. So you haven't really got what the argument is of cutting down costs by going to those plans. But that keeps the insurance companies in the game, so that takes them away from the political argument that you might have otherwise, and is more likely to be politically palatable as the next step if you did it. That goes back to the issue I had before. Those are still pools, so they may still have the same issue. They're not everybody, which levels it out. So if I had to guess, that's the political path I could see somebody going down if you really got in Congress and really wanted to get it done. You could do the same thing at the state level because most of the states also contract out to Medicaid managed care companies, and so you just put them in. I always thought that was an easy way to do for the counties that didn't have coverage under the ACA, is just open it up for the Medicaid managed care plans that are in those counties, and that's an easy way for people in those outlying counties to get some access.
Tying what you just shared with what you had earlier about provider-sponsored plans,
Yep.
that's the next element is there's been some benefit moving from the state-administered plan to a managed care company-administered plan. But when the providers are just a place to go for care and not part of managing that plan, that's a problem. Because we already have evidence that when the providers are part of managing the care, deciding what's covered or where referrals happen within a certain delivery system and such, it's much more effective. So I think that would be a next level not just the existing kind of insurance, private insurance plans that manage Medicare and Medicaid for the government, but changing the nature of who gets to manage it to have it be provider-sponsored, since they are literally providing the care. Take out some of that bureaucracy in between.
But the issue you have there, Susan, is that, again, the pooling.
Yes.
Is the pool big enough for any individual provider to not bear undue risk? The game in healthcare is allocating risk to different parties. And we tend to be pretty blunt about that. We throw it all one way or all the other way. And we're not being very subtle about who can bear what risk in what way. And so some of the managed care, some of the contracts that Metro's got that have an incentive built in for the total cost of care, but they're not bearing that full amount, is sort of an in-between thing. So you're going to find some interesting contracts, I think, that definitely Susan's involved in, that sort of allocate enough risk to get your attention, and to focus your thoughts so you can actually do a better job with the population, but not so much that you become an insurance company. So that's the real interesting question, is can you keep enough risk at a very large pool level so that you don't have to bear that. The ACA, part of the inside baseball part of the ACA, is there are reinsurance mechanisms and other ways to deal with that basically the feds reneged on. And that's just screwed up the pool. They would have taken some of that risk away from some of these plans and made them more viable. Instead, they threw it all back on them, and the plans had to raise their prices 20% to cover that extra cost. That's ridiculous. That was totally untoward. And I'm livid about that because it makes the experiment not work very well.
All right. So what I want to ask, and
We never answer your question, by the way. So
I know I don't really know why I'm asking, but it's good practice for me being up here. So okay. So what I want to ask is, we're talking about these incremental steps. What would have to change? What we have in place? It's such a multi-tiered system. What were to happen if, say, tomorrow we just said, you know what, we're going to have universal health care. We're going to go to single payer. It's going to be government payer, like the UK. It's going to be higher taxes. What does that look like? How do we get there? Like, what happens tomorrow if that were to be what we were to do? Just blow everything up. That's what I want to have you talk about.
Civil war, I think, is the right answer. But then.
I'm glad you brought up the taxes. That was going to be my first reaction, is there has to be some starting revenue for that.
Right.
And that would be a tax hit. And in general, when there's polls saying, are you all for universal health care, or call it single payer, whichever way they want to use the term, everyone's for it until the next part of the question, if it includes an increase in your taxes, well, now I'm not for it anymore, right? And that's part of that, when you talk about a cataclysmic change, it's getting a quick change to a whole new system needs that funding. Mm-hmm. And the funding has to be there to support the benefits, or it falls apart. The efficiencies that, eventually would come take a while to catch up. You can't just, have care rendered with no reimbursement for years until finally, the system catches up. So that's a huge barrier. And as a politician, I think that's going to be the toughest thing that they would face. That was my first reaction.
I don't know if there's not enough money already. But the question is redistributing that money. There are winners and losers in that, and so, that's and to JB's point earlier, is there the political will to do that? I think that's the question. But, we already spend a lot of money. And as JB or as Susan pointed out earlier, we get pretty miserable results, in terms, so our rankings in the state, even with the expansion of Medicaid, have not particularly improved. Now, some of those are driven, and a lot of that's driven, though, by stuff that's sort of separate from coverage, that's related to poverty and things like that we've not particularly addressed. So, it'd be nice to maybe wake up tomorrow and the political will existed to do these things. That would be an interesting experiment. So, but I'm not sure that the money isn't already there. I just don't know enough. So,
just to your point, John, the specifics from the California report I mentioned earlier, They think that you can save $15.4 billion, which doesn't mean anything, but that's enough to take care of the expansion of this. If you do three things, they've got three. One is the use of global budgets and integrated health systems. So they're basically saying Kaiser. Well, Kaiser's not here anymore, but they're talking about Sutter and a few other the big systems out in California. So can you do a global budget for those people, like Canada does? That's the best example. The UK does this too. Can you do something like that, which basically means everybody has to live on a fixed budget, and you don't have an incentive to do more things. So you have to choose which things you're going to do, and part of the question is what does that budget cover? Does it cover everything for a population? Just cover the different hospitals and services or whatever? But global budgets is one, and with an integrated health system. The second is patient-centered medical homes, which is sort of an inside view, but it basically means you're going to have one primary care doc that's going to, or practice that's going to take care of you, and they're going to be the player. They're going to coordinate the care across all the other players. So you shouldn't be wandering around doing all sorts of things. One of the biggest insights from having an accountable care organization is how much of the service that you thought you were taking, how much of the service to the population you thought you were taking care of isn't coming to you. It's going someplace else. It's like 50% or something like that for most of these. So you thought you were taking care of this particular patient. It turns out they're wandering all over the place getting care. Uncoordinated, too much expense, too high a price, all over the place. Just managing that the way that most people in healthcare would say is the right thing to do for the patient to get quality saves money right off the bat and it gets a better product. The third one is palliative care, and I don't know quite what they mean, but I think that's a code word for end of life. So can you do things at that point where we spend this huge amount of money and not do heroic stuff when we shouldn't be doing it, and actually have people have palliative care rather than wildly invasive care? My mother just died a couple months ago at 103, I might add. Thank you, Mother. So I'm going to live forever. I've just been planning right now.
Go back to work.
And she lived a good life. Lived with my sister. Didn't have extra care. We had all the living will and all that stuff. She died in her own bed with a hospice nurse there to help her, and it was peaceful. I mean, she was laughing at my jokes until the last week. That was my test. My son was sitting next to her singing hymns as she died. It's just, that's the way it should be. It's a beautiful model. But she knew that, and she had enough time to plan it. Well, most people would want to die that way too. That's what I plan to do. Although I don't know who's going to sing to me, but that's a different issue. Anyway, those three items were enough in their view to pay for the whole expansion, which leads you to your point. But it's not just a random, just going to whack away at everybody and allocate the money someplace else. That kind of hatchet approach is not going to work politically or from an economic or from a system point of view.
I have one other comment on that, is that surge of that change all of a sudden might bring on a second reaction, which is this coverage is all great, thank you, but now I want to supplement it. I want more. And that's what's happened in other countries. The universal coverage is there. It's available to all. Many of them don't have restrictions on where you get that, but they also have other coverage that private citizens pay for to supplement it. In Canada, they supplement it with things that are not covered. In England, they supplement it with things that are covered. They just want faster service. They want faster access or a different choice of providers, or so it's not pure anymore. There's really not a single pure system like that doesn't have some exception to the rule to make it work well enough in any given country. And we'd probably see the same reaction here.
All right, thank you guys. Thanks for dealing with my questions. Now we're going to go on to your questions, so yay. All right. So our first one I'm going to go to is, how significant is the health insurance lobby in fighting attempts to develop, they say Medicare expansion, but I just want to expand that to any of these attempts. How powerful is the health insurance lobby?
I mean, who's more powerful? I mean, you have the insurance industry, you have pharma, you have hospital. I mean,
What do you want to compare it to?
yeah. I mean,
right?
what did we? It was Nick Mulvaney, who's the budget director for President Trump, who was quoted yesterday as saying he only met with people when he was in Congress who had given him campaign contributions. I mean, I mean, and that we just came right out and said it. So yeah, they have a lot of power. They finance the congressional races. I mean, campaign reform should be a part of this too.
I think it's a big issue. One of my eternal stains in my soul is I can think of two events when I was running the insurance company. One is meeting with the Speaker of the House, and I can't remember who it was, a woman at the time.
Joanne Davidson.
Yeah, it was Joanne, I think. And it wasn't a big deal, but I'm sure there was some money involved. I can't remember. We made a campaign contribution to her. The other is giving $1,000 to our former county commissioner, who is now resting in jail, totally for access, no question about it. You know, it's Mick Mulvaney. If you didn't pay, you didn't get to talk to them, and you didn't have. Now, to the credit, I went and talked to Dennis Kucinich at one point. Never made a campaign contribution. He understood exactly what I was talking. We had 30,000 Medicaid enrollees, and that was sort of the big issue. He understood exactly what I was talking about. There was a roll call vote. We walked over together. I thought, this guy gets it. You know, he understands it. So there are exceptions to that. I think there are definitely exceptions to that. But does it make a difference to have access? Absolutely. There's no question about that. My sad part is that, I hope I'm not offending anybody here, it's a lot easier to buy access. I started to say buy without access, but to buy a state legislator than to buy a federal legislator. They come at a much lower price point, so, but you have to make certain contributions. The nursing home industry has been incredibly effective at doing that, which is one reason why Medicaid pays nursing homes the way they do, and other people haven't. Now, is it enough to derail it? In the Clinton approach, they clearly didn't understand the politics, and they didn't get the right people in the room. With the Obama people, they got basically the AARP and the drug industry together, among others. Speaking of power, and ARP wanted to get rid of the donut hole in the Part D plans. If you've got the Part D, you know what I'm talking about, that part where you don't get any coverage. They desperately wanted to get rid of that. The drug companies desperately wanted to not regulate their prices and not allow importation from other countries. They crossed the deal. And the drug companies basically said, we'll make the donut hole go away over 10 years with discounts and stuff like that, and you get your donut hole taken care of, and we'll do hands off of the pricing. That's the reason why we're still wrestling with drug pricing now. And we didn't solve that problem. So it's politics. You know, there's a trade-off going on.
Surprise. Okay, our next question is, what is wrong with the VA system for all? Why can't we do that?
I don't know, that's not something I know about, so.
I'm a big fan of the VA. I don't know, have you had any experience with the VA?
Not enough to
You know, among other
be as
things.
entertaining as you will be on it.
Well, among other things, the VA has got a really bad rap because that thing in Phoenix and some of the access issues and stuff. Overall, they've done a great job of quality. They've been a leader in the quality side. There's no question about it. Overall, they were ahead of the game. It's an integrated system. The incentives aren't to do more, it's to do it better, and they've done overall a pretty good job. I think the trouble is that if you expanded that out, again, you'd have a huge amount of financing. You'd have to come up with it someplace, number one. Number two, all the existing providers would see their livelihood disappear, including all the jobs as the largest employer in the city of Cleveland. And they want to go exactly the opposite directions, which is why you find the movement in the Republican administration now to privatize the VA. What that means is, let's close down the VA, contract everything out to the provider, to the independent providers. That's all political, as far as I'm concerned, because the VA has done a great job with those veterans, with some some outstanding exceptions, but they've basically done a great job. So I see it's like the other stuff, Ginger. It's financial and political, which is what most of the answers are to your questions, actually.
All right. Where was I going here? Okay, we have a question here this person is wondering, what is preventing states from coming to a consensus on some kind of path forward?
I think I just answered that.
Political.
Yeah.
I mean,
You dealt with the legislature, John. You know more than anybody.
well, but I do think, I do think that states sometimes there's a lot of interesting things that happen in states. States sometimes have more flexibility than the federal government. They have tried to do things, some things have worked, they try to do things that I think are also bad, as well as do things that I think are good. But I do think, states are kind of interesting because they're actually good places to experiment, because you can experiment in a sort of a limited geography, see how it works. Whatever California might try to do, or people always point to Vermont, and people in Ohio would say Vermont is like the size of one city here or whatever. It's hard to sort of compare the two or whatever. But I do think states have a role to play, and I do think they can experiment with things that we might not be able to accomplish at the federal level. I mean, nothing seems to get through Congress, so at least states are able to function a little bit better than that.
Okay. So we kind of touched upon this. I think it was Susan. I can't remember. One of you said this. But anyway, we were talking about, how universal coverage or single-payer coverage works in other industrialized countries. And we're saying that there's this idea that, we have something here already. We need to, build on what we have, make small changes, try to figure out a way forward. But why can't we just use the plans that they have in place? Why can't we switch to one of those plans? Or is there a plan in another country that would be a good model for us?
Yeah, I think that might have been me in the beginning who touched on that. So what I was referencing then is our starting point is different than those other countries' starting point. So we're used to things a certain way, good, bad, or otherwise, right? I mean, we're happier than we let on, but we like to bring up the things that, are concerning, and we've talked more about those things. Some of the changes we'd experience to mimic someone else's universal health care program would be takeaways for us. It might be takeaway of choice of providers. It might be takeaway of speed of getting care, because that's literally how they built their program. If you want the coverage and the provider you choose, or the provider you're allowed to see in whatever area has a waiting list, you'll wait if you want the coverage. Otherwise, you'll go buy supplemental coverage, and that may not jive with us. We're not used to saying you can have it, but you have to wait in a long line for it, or do without it. Or the limit of your coverage means, go without this procedure, even though you want that, because sorry, it's not covered. We're not used to those limits, but it may be great. But what I'm saying is that we're trying to mimic some other country's way, and our version of that way wouldn't sit with us the way it's been adopted there, because we actually wouldn't transition from the same history that they've had.
I think, I understand sort of the political, but I mean, people are already waiting now. I mean, because, so the only reason I say this is because somebody told me, a friend of mine who's a physician told me this last night, and I won't say, hospital here in Cleveland, that, people who need psychiatric care need to see a psychiatrist. They have to show up at this hospital every morning, like at 7:30, to kind of get in line to be assessed to see whether they might be able to get an appointment a month from then. I mean, these are folks who are not at danger to themselves or others, don't need to be hospitalized, but just need to think they need psychiatric help. So I mean, we've already got some of these. So there are people who aren't covered today who don't. You see, like in Medwish and some of these places where people will line up all day to get health care coverage of some sort. So.
Would the universal health coverage, though, make that better or worse?
I think in general, I think, with the Medicaid expansion, I think we saw that it made things better. That, that people were, I think there was some concern with Medicaid expansion that it was going to lead to these long waits, that people wouldn't be able to get in to see anybody, and I don't think that was the case generally. There may have been examples of that, but I think generally people had better access to care and reported that they had better access to care. So, would it be the same if we actually covered everybody? I don't know. But I think sometimes, I think, and there's states that haven't expanded. I mean, one of the reasons why only 1 out of 5, why America's Medicaid coverage doesn't look like Ohio's, is because Ohio expanded, and states like Texas and Florida and some of these other big states didn't expand, and so those folks there don't have access to this coverage and stuff. So these aren't easy questions, and I think they're bigger sort of cultural, as I think you're saying, Susan, that there's some cultural issues there, things that we're used to. And I mean, part of the challenge with any of these measures is that most people in the United States have coverage, and they are very suspicious of anything that would either make that coverage more expensive, give them less access to care, and so that's, I think, one of the things we have to wrestle with. I think, and I think that's one of the reasons why it's so hard. So.
I mean, any of the stories that I've written in my decade as a reporter, the most feedback or the most kind of debates that people get into are over the healthcare stories. It's something, I mean, obviously it's very close to home.
Right.
People are worried about their health. So, I mean,
and it's not just coverage, it's also cost.
Right.
Because how many GoFundMe pages are there for people's healthcare costs? I mean, it's like if you go on GoFundMe and switch for people, who are trying to pay their deductible or pay whatever it is. I mean, but I mean, getting to cost is difficult too. It means making some really, I think, tough choices about what we cover and don't cover. So. It's not as simple, and we knew that when we came here tonight.
On what's expensive, the Affordable Care Act is really interesting because what's affordable is defined by the law, and if you're just above the poverty level, affordable is 2% of your income, and at 400% of the poverty level, it's 9.5% of your income. I always thought, where in the world did they get those numbers? So I wrote to Jonathan Gruber at MIT, who was one of the people, the economists that worked on this thing, and he sent me a study where they actually went back and looked at survey data of how much at each income level it took for people to feed themselves, to do the rent, do the other sorts of stuff, and how much discretionary income they had left over. And that's how they came up with 2% up to 9.5%. That's for the premium. What they didn't do, though, is look at the cost sharing. And the argument was the cost-sharing subsidies will take care of that, which they were designed to do. And it wouldn't have been so much of a big issue except that the Trump administration canceled the cost-sharing subsidies. So basically people are stuck there with $5,000 deductible plans and major copays when they have no money. They obviously can't afford to pay that. Right. So the Affordable Care Act, even though it was designed to try to be better on that, basically got torpedoed by the administration in a way that made it unfeasible, that those people just clearly can't afford to do it, which means either they don't come when they need the care, which is a huge problem, or they do come and then it's a bad debt for the systems, for the people that are providing it. Both of those are really bad solutions. So again, the ACA had the right idea, it just didn't take it very far, and then it got torpedoed. So it would have been interesting to see how well that worked out in terms of affordability, because the fundamental question is, you want people to be careful about their use of those resources, but you don't want them to be deferred from using them when they really need them. And Jonathan was actually trying to figure that out. But the experiment went off the rails because of these other sorts of stuff. We do have data on that, so it's a legitimate thing. The next step is to change the Medicaid program, and we haven't talked about this with the waivers. Most of the action are going to be at the state level, and Ohio is I don't know where the waiver is now, but it will be out there, which will have work requirements. It'll probably, do you think it'll have a HSA attachment to it?
No.
It won't have an HSA attachment. In Indiana, the program set up a $1,000 fund, which you use then to help pay for part of the expenses, and then you get more money put in it if you do good stuff, and you lose it if you don't. The idea is people need some sort of financial incentive. So that principle is right. It's how well you do it and how much risk those different parties can bear. And, if you didn't have any copays and deductibles, we clearly would have excess utilization. I don't think there's any question about that. We'd have people using systems more than they probably should, and the rest of us wind up paying for it. If you do too much on them, then they're not going to get what they need. So how do we design that? Well, we need to figure it out, and we need to figure it out soon before any of these things get off the ground.
All right, our next question is, this is a unique approach. They want to know, is there a way to model healthcare in the way that utilities are structured?
Given the history of First Energy, I don't know if that's really the right idea.
I was just wondering, they're trying to make us pay for those nuclear plants, so currently, so, yeah, I don't, maybe thinking as healthcare as a public utility.
Well, actually, when I first got involved in healthcare, that was a popular topic, that healthcare is a utility. And I remember having people in class at Harvard that were playing around with that sort of idea. The idea of the way it used to be for utilities, public utilities, if you had a natural monopoly, then you looked at what the costs were to provide that service and added on a fair return on investment. Not too much, not too little, just enough to help them pay for the capital cost of what they were doing, which is First Energy's argument is they don't have enough to be able to pay for that capital cost. And that's, it's an arguable point. What we did, though, over the years is we decoupled that and made it a competitive market. So we sold off the generating capability, and now we just have the line, basically. CEI doesn't do what it used to do. So, and even Cleveland Public Power doesn't do what it used to do. They buy stuff from Niagara, from Quebec. So we don't really have that model anymore. The telephone company got decoupled. That's the way the AT&T rates used to be set. Now they're all competitive because of all the stuff that's happened with wireless. So, there aren't many places. I guess gas line transmission is still a public utility model, I think. Federal Power Commission does that. I'm trying to think of any place else that really has that model, and I can't think of much because we believe competition is great. So it's going to solve all of our problems for us. Just let the market do it. Get the government out.
All right, this person wants to know, what steps would we have to take to make single payer truly universal? And should we dissolve private insurance entirely? Don't remind them that.
To make, the first part was make private insurance universal?
To make single payer truly
Single payer
universal.
universal.
I'm not,
I guess,
I think Medicare does that.
if you want to make it universal, you would just cover everybody.
Cover everybody, yeah.
Yeah, you would just say everybody's covered. You just cover everybody, so.
To that note, and this is just something someone mentioned in a card, but it's not really a question. It was just the idea of, we talk about not everyone being covered even under the ACA. Who are those populations who aren't covered right now? I'm not sure that that's clear.
Well, a lot of them in Ohio are people who are eligible for coverage, actually.
They didn't
That's the
sign up.
thing. The big portion of the uninsured in Ohio are actually eligible for coverage under the Medicaid program. And the children that are uncovered are eligible for Medicaid that are uncovered. So, and part of that is because, we have very, bureaucratic processes for getting people covered. It's difficult to get coverage sometimes. So that could be part of it. But, one of the things that was a truism about Medicaid was a lot of people went to get coverage when they got sick. Their coverage might have lapsed. They might not have re-signed up for it. They might not have reapplied for it. But when they got sick, when they showed up at MetroHealth and the emergency department, and were faced with those huge bills or whatever, like, okay, we're going to get our coverage reinstated. So part of it's that. So there's some personal responsibility there, but it's also, I think, it's a pretty complicated process and not particularly easy for people to maneuver. So, so.
Well, in those cases, they had presumptive eligibility, I think, so you could say if they qualified, you cover that event.
That's right.
But I think we played around with that, so that's not as
It's still
true.
there. It's still there for hospitals.
I thought we were trying to get rid of it.
Federally qualified. The Trump administration would like to get rid of it, and some states are trying to get rid of it, but it still exists here in Ohio. So.
It brings up one of the other problems. We've been alluding to this. Things that are confusing, complex, take a lot of time, become barriers, and you lose interest in hitting your wall against that head, and so you don't use what's available. So it might as well not be available. So that's another problem that needs taken into smaller pieces and made much more efficient and easier on the consumer.
Well, the other is a design question, too. That the behavioral economics is very helpful in terms of thinking through some of this, and an opt-in versus an opt-out is one of the key decisions that you make. So a lot of people don't take their 401k, for instance, for their retirement plan, because you have to make a positive decision to get into it, and therefore you're missing the match from your employer. Well, that's ridiculous. So places where we've made that an opt-out rather than an opt-in, then basically everybody gets it. So you help them, you design the process so that people automatically will do the right thing. They have to make a positive decision to do the wrong thing. So why do we make it hard? Well, we don't want to spend all that money. I mean, it's pretty clear. It's for budgetary reasons. You could do it the other way around and say, we assume that you're qualified for this, and it's only if you aren't qualified that we'll opt you out of it. You'd have everybody covered. I mean, that'd be an easy way to do that.
Well, yeah, so,
but it'd be very expensive, so.
I mean, so one of the proposals, one of the things that the Trump administration has proposed to states is allowing states to do Medicaid redeterminations every quarter, saying that you have to come in every, and it is such a cynical way of just cutting the program. It is meant to cut the program. You know, that's what we used to do in the old days. Say, well, you got to come in. You know, when I was Medicaid director, if you were age blind disabled, you had to get redetermined. The federal government allowed you to do it yearly. We did it every 6 months. Well, if you're age blind disabled in January, you're likely age blind disabled in June. And so we went as long as we could. We went to a year long so that people didn't have to come in. And what we were able to show the state in order to do it, because I had to prove it to the budget people, was that the churn of the program, people coming in, coming off, coming in, coming off, cost us more than it did to just keep people covered, you know, for as long as we could, as long as the federal government would allow us to do it. So there are efforts underway to sort of undo some of that and to make it more difficult. And they are strictly budgetary. They are strictly about trying to cut people off the program and save money. And the question is, does it actually? I mean, it doesn't really save money because everybody is eventually going to get care, but they're going to get care at a much later point and at a much more costly and much less effective. And so I think that's a challenge. So I think we have to be very sort of diligent about sort of being aware of those things, because those are really sort of bureaucratic things that don't get a lot of attention. Like if I tell you 6-month redeterms or 4-month, you know, it's so geeky and policy-ish that people don't, but those are the kind of things that really have an influence on people's care. Like when, you know, in the Strickland administration, we did, I think, 4 or 5 expansions. We expanded pregnant women, coverage for pregnant women. We expanded for people with disabilities who want to keep working. We expanded it for children and for parents. And those were all good. But when I look back, what we should have done was simplify. If we had simplified the program and made it easier for everybody who was already eligible to get covered, we would have covered more people. You know, that has always sort of stuck with me. We were so anxious to cover these groups that we sort of missed, I think, the more important picture of let's simplify the program for everybody so that people can maintain their coverage and stay covered rather than sort of going off in these little sort of subgroups.
All right, thank you. We only have time for 1, maybe 2 more questions, so
We'll keep it brief.
I'll just try this out. So one person, this should be a pretty quick answer here. Are there any Republican supporters of universal health care coverage?
Ooh.
Wait, somebody in the audience may know. Who is it?
We've had discussions with state legislators who said, I won't say it publicly, but if it came for a vote, I'd vote yes. And that, so, yeah.
Publicly, we all kind of know the answer. All right, and then this question I just want to throw out there. It said, as concerned citizen, if you're someone who wants, you know, to see a change in how healthcare is delivered, if you want to go toward this universal kind of model or single payer model, how can they best express their interest about that? Can they fight the insurance lobbies? Just what do they do to try to let their lawmakers or to try to, you know, actually create change on this front?
That's a great ending question. So I'll start, but I'll give you guys some time to think about what you might chime in on. I think first and foremost is understand the current system, because I think that's where it gets hard to get heard. You know, if we can't describe what we're trying to change really well, we're going to lose the attention of those we're trying to influence. And that means just trying to spend some more time. So maybe it's something with eligibility or enrollment, or like getting coverage that we say is out there, but you're sure it's not because you've hit every barrier out there. Spend some time deciphering that, so you know which kind of program you're talking about, which barrier, which eligibility, whatever it might be, and that way you're very specific in your ask. It's not a generality or a presumption. It's something that's you've got the facts gathered on. Because I think too often it's easy to get into the always, everywhere, everyone, and you're really talking about a specific barrier that you're facing, and that's why your passion for change is getting to this level. So I think that build the knowledge, understand what you're experiencing is the first step. And I'll let you guys chime in on that.
Well, I pick up on what you said. I think that saying single-payer, universal isn't very helpful. It's a slogan. It's like being for motherhood, you know. So can you be more specific and say, and this is Bernie's genius is, he's made it really clear, Medicare for all. It's pretty simple. Everybody understands Medicare, more or less. They don't understand the details of it, but they know how Medicare works for them and their grandmother and such. And that's easy. Yeah, I love the system. Let's expand it to everybody else. Medicaid for all is a little harder because not everybody has that. But at least that's a policy objective that you can sort of debate. The California one is interesting because they're trying to tackle everything, and I think politically they've been through this multiple times and hadn't gotten any place. And by doing everything, they probably aren't going to get anything. That's probably the issue. So, are we going to change? Yeah, I think we're going to keep changing, but it'll be incremental, in spite of the fact that people would like to throw the whole thing out and start over again. It's just really hard to get rid of it.
I think, I've been doing this for a little bit, but you got to be persistent.
Yeah.
You know, I received good advice from a friend of mine when I first started doing this work. She said, always be the last one in the room. You know, don't ever leave, because it's those last conversations in the last 5 minutes or whatever that sometimes change things.
Or get on Fox News. You can do that.
Or just when the president's watching. But be persistent. I think, the other thing that really, I have, when I was Medicaid director, I dealt with a legislature that was controlled by Republicans, both the House and the Senate, the first year I was there. And I guess the thing I've also learned, not just be persistent, but be polite. Even people I disagree with, I'm nice. I listen to what they have to say. I offer, countervailing arguments or whatever, and and I keep at it because, I have seen people change. I've seen people change their views on these things. Sometimes it's a personal experience that makes it do it. Sometimes it's somebody in their family or whatever. And so you never want to close a door with somebody. You always want to keep the dialogue going. You always want to keep talking. You always want to be that last person in the room. And then I also think you need to elect the right people. So, and I'll leave it there.
We are hitting our time limit, so I just want to thank all of you for coming out. Thank the League of Women Voters for having us here today to talk about this. This is how we spread information, by discussing it, by talking about it, by learning from people who might know more than us. So thank you all for coming. I hope you have a good night and be safe. Thanks.
Good job.